Hey, all you future medical coders out there. So let's talk about spinal injections. I know, it can feel like you're trying to learn a whole new language, right? Well, you're in exactly the right spot, because today we are going to crack that code together.
I mean, seriously, does flipping to that 62,000 series in your CPT book just make your head spin a little? Yeah, trust me, you are not alone on that one. It's a super complex section full of all these little nuances, but that's exactly why we're here. My goal is to help you swap that feeling of confusion for some real confidence.
All right, so let's get right into it. The secret isn't trying to memorize dozens and dozens of codes. I mean, who could do that? No, instead we're going to build a mental framework. Think of it like a cheat sheet for your brain, built on 4 simple, unforgettable golden rules you can use every single time. Okay, first up is rule number 1, the all-inclusive rule. I love this one. Just think of it like a combo meal. You get the main thing, the side, the drink, it's all included in one price. Well, in the world of coding, we call that bundling.
So here's the deal. A whole bunch of spinal procedure codes already include the imaging guidance and any contrast they use. This is huge. So things like fluoroscopy, which is basically a live X-ray, or the contrast eye, a lot of the time, those are already built right into the main code. You absolutely do not report them separately. Seriously, this is probably the biggest mistake new coders make, so let's drill it in.
And take a look at this. It shows you exactly what I'm talking about. See those code groups for epidurals, like 62321 or 62323? Fluoroscopy is just part of the package. It's an inclusive component. So you're not going to add that separate guidance code, 77003. Same thing for myelography. The imaging is required for the procedure, so of course it's bundled in. So here's your new habit. Before you even think about adding a separate code for imaging, you got to stop and ask, is this part of the combo meal? Always check first. All right, moving on to golden rule number 2. Let's call this one coding by the clock. This is all about time. And when a catheter is involved, there is one and only one super important question you need to ask yourself. How long was it actually in place? And the difference is actually really simple, but it is so crucial. Here's the split. If that catheter is put in, used, and taken out all on the same calendar day, you're going to be looking at codes in the 62320 to 62323 range. But if that catheter stays in for more than one calendar day, maybe for a continuous infusion, then you jump over to a totally different set of codes, 62324 to 62327. So it all boils down to that one thing. Same day or multi-day? That single question points you to the right family of codes every time.
Okay, on to golden rule number 3. And guys, this one is a game changer. It clears up a massive point of confusion I see with students all the time. We're calling it the location, not destination rule. And it's all about one simple question. Where did the needle start?
Now, this right here is pulled directly from the CPT guidelines, so this is like the law. You should practically tattoo this on your brain. It says, code selection is based on the spinal region of needle or catheter entry, not where the medicine spreads or where the catheter tip ends up. I'm going to say that again because it's just that important. We care about the entry point, the starting point, that's it. Where the medication wanders off to later doesn't matter for coding. So let's look at a perfect real-world example. Say the physician does an injection in the lumbar region, right? But the medication spreads upwards into the thoracic area. So what do you code? Do you code both? No way. Do you code thoracic because that's where it ended up? Nope. You report the lumbar code and only the lumbar code. Why? Because that's the entry point. See? It's simple, it's clean, and it will stop you from making a really, really common mistake. And that brings us to our final golden rule, number 4. This one helps you figure out the type of procedure by asking a pretty basic question. How did the doctor actually see what they were doing? The CPT codebook breaks this down into 3 totally different ways they can visualize the anatomy. First up, you've got percutaneous. The word literally means through the skin, but the key thing to remember here is indirect image-based. The doctor isn't actually looking at the spine with their own eyes. They're watching a screen, a fluoroscope or a CT scan, to see where the needle is going. It's kind of like they're using a GPS to navigate. Okay, next we have endoscopic. Now this one also uses a screen, but it's totally different from percutaneous. Here, they're inserting an endoscope, which is basically a tiny little camera right into the body. So the physician gets this continuous live video feed of the anatomy. It's still on a screen, but it's considered direct visualization because they're seeing the real thing through a camera, not just an X-ray image.
And finally, there's the open approach. Think of this as good old-fashioned surgery.
The doctor makes an incision, a surgical opening, and they can see the anatomy directly with their own eyes. No screens, no cameras, just direct sight. And knowing the difference between these three, percutaneous, endoscopic, and open, is absolutely fundamental. It's how you'll find your way to the right family of CPT codes.
So there you have it, 4 simple rules that are now part of your new Coder's Toolkit. These are going to help you tackle spinal injection coding with way more confidence. So let's just do a super quick recap to make sure it all sticks. All right, here's your toolkit all in one place. First, you've got the all-inclusive rule. Always check if imaging is bundled in before you code it separately. Second, the time rule. Is that catheter a same-day thing or is it multi-day? Third, the location rule. Remember, it's about the needle's entry point, not where the medicine ends up. And finally, the visualization rule. You got to know the difference between percutaneous, endoscopic, and open. So now you've got the toolkit, and I want you to think about this. As you start practicing and looking at coding scenarios, which one of these rules is going to be your go-to? Which one just had that aha moment for you and cleared up the biggest confusion? Seriously, having this framework is going to make you a sharper, more accurate, and way more confident coder right from day one. You've got this. Good luck.